Hello. Before we get started, somebody lost their glasses, and they will be at the table right out here. So if that's you, go grab them. But I want to welcome you to Valve Awareness Day 2025. I'm Rebecca Ullman. I lead the Science Centers at the Minneapolis Heart Institute Foundation. And is this my clicker here? Okay. Thank you for being here on this balmy Saturday. We're glad you came out. And also a huge thank you to our sponsors and exhibitors, Abbott, Edwards Life Sciences, and Medtronic. Their support helps make this event possible. Oh. The schedule of events you can find on your table in front of you. You'll also find a QR code on that schedule. If you could be so kind at the end of the program to scan that QR code and provide thoughts on our program today, we'd really appreciate it. Also on your table, you will find note cards and pens. So if you have questions that come up during the program, feel free to write those down. At the end of the presentation, someone will come around and collect those, and we'll use those questions for our Q&A session at the very end. Okay, so for those of you who aren't familiar with the Minneapolis Heart Institute Foundation, we are the nonprofit research and education arm of the Minneapolis Heart Institute. We are based at the Abbott Northwestern campus, and we partner with Abbott Northwestern, United, and 42 satellite clinics around the cities. And that really helps, those strong partnerships really drive our impact in heart research and education. And we're busy. We currently have over 220 active research studies. Our physicians see over 3,000 research patients a year. And the impact of that research is really shared on a global stage. So in a year, we will have over 650 peer-reviewed publications and presentations. And again, these are around the world on a global stage. We'll have over 11,000 hours of professional and community education each year, and we are helping to train the next generation of researchers. We're very proud of our internship program, which now boasts 244 alumni, many of which have gone into medicine. I do want to talk a little bit about the expertise we have in valve science right here in our backyard. We are very fortunate to have some of the world's experts in valve science here in Minneapolis. As you listen to the program today, you may start to appreciate that treating valve disease really requires a team approach. And the panelists, our expert panelists we have today, Drs. Paul Saraja, Nadir Ahmed, and Sebastian Atura, along with their colleagues at the Minneapolis Heart Institute Foundation, have pioneered a lot of the therapies that are in use today, and they really work tirelessly on the next generation of therapies. Believe it or not, our physicians are too humble, probably, to talk about this, but their accomplishments on the world stage are impressive in and of itself. But I think what sets this group apart and makes them one of the best, if not the best groups in the world, is that they are laser focused on each individual patient. And whether that care, the best care is for something that's already available and approved, or if that involves research. So as I said, we are a nonprofit, and the work we do is driven by philanthropy. So we, of course, are incredibly grateful for our donors who make this work possible. So thank you all for being here, and I will turn it over to Dr. Saraja.
Sorry, I get up and I drop my mic. Sorry about that. Well, good afternoon, everyone. I want to welcome you to our annual event. Today is Valve Heart Disease Awareness Day. This is an annual event where we get together and share what we do to treat our patients with valve disease and how we can help the world as part of a greater good. And so we have a nice program for you, and this is meant to be educational, interactive, and it's for you. So please, when you have a moment, there are cards on the table, as Rebecca mentioned. Fill those out, and we'll collect them and answer all the questions as best we can. But to kick off the agenda for today, I had the pleasure of introducing this patient video that was made. This is a video of Gloria Collin, who is graciously here with her husband. And really this, I think, sets the stage. It highlights a lot about what we do from our research and how research can help patients' lives. And she is somebody who has been gracious in sharing her story. So without further delay, we can start there. Thank you.
Hello, my name is Gloria, and I love to dance, and art, and music, and theater, all kinds of fun things like that. In this play, I played Lady Boxington, and then, of course, took care of the kids a lot, the grandkids. Back in 1986, I was doing jazzercise 5 times a week, and I thought, oh, I think I have walking pneumonia. Went into the doctor, and it all turned out I had Hodgkin's lymphoma. And so from there, it was cobalt radiation. A couple years before COVID, I could really tell my heart was not quite right. There was something not right. Then there was a point where I had to see a cardiologist because of the blood pressure issues, and they were watching the heart, and in particular the aortic valve. They saw some leakage, which got worse and worse and worse. I had an appointment with Dr. Orlandi, who's with the Minneapolis Heart Institute, and he said, I want you to see Dr. Saraja. Introduced me, and my appointment was on a Tuesday, I believe, and on a Monday night at 1 in the morning, I was 911 into the hospital, Abbott. It was regurgitating 80% into the heart. And Dr. Saraja, he needed to go in through the vessels and do his magic. And what happened was I went in an experimental study that he had to really fight to get me in. The research study was vital because without me being in that research study, I would not have this wonderful valve that saved my life. It's just so reassuring because you're being checked constantly, and if something's not right, it's pinpointed immediately and dealt with. I felt like I could tackle the world for 9 days. And I had developed a left heart bundle branch, and I got my pacemaker. Of course, doing all the visits with the heart to be sure the valve was working properly for the study. Then they'd have to watch it every 3 months, 6 months, year. I look forward to the appointments, and this last one I was so looking forward to because I knew they'd do the echo and see how everything was doing. And I don't mind the appointments. It's much more reassuring to be in it because you're being constantly monitored, and it was just a perfect valve working perfectly, but they noticed July 2023, it was obvious the mitral valve was leaking, and we got to the point where it needed to be replaced. And there again, we must go to a study. I actually got it in January of 2024. And then we proceeded on with watching the Cephea mitral valve. When they went in with the mitral valve, they went into one heart chamber through the septum into the other heart chamber, made a hole. Well, it had healed after the surgery, so I was just fine. Although it opened up, I think, within 6 months. And the team went in and they closed it up. And I just had the annual for this Cephea valve, and it's good. And now we're just continuing to watch the heart and work on the heart function. I'd like to be able to just get back into some of my dancing classes, Nia and Tai Chi. I'm cooking now more. I mean, there was a point where I wasn't even cooking. They really need to pursue the goals of research and keep digging in and finding new options and new ways of dealing with the body. They wanted to deny me, and I'm just so grateful that Dr. Saraja continued to pursue and say, no, she's a good candidate. I believe this is going to work for her. I want this to be in her life. I think I want to just defy the odds and prove prove to the world that you can have all this happen and still survive and have quality life. So I think that's part of my motivation.
So every patient's story is unique, and Gloria's certainly is, and it's a great example of how, with research and clinical treatment, that lives can be affected in a beneficial way. And really just want to thank Gloria for sharing her story. She's here with her husband, Jim, and it's been just amazing to be part of your lives. Thank you. Gloria did mention my name a few times in here, but it's not just about me, okay? We have an incredible team here, and this team, it's multidisciplinary and involves people who are general cardiologists, surgeons, interventionists like me, and then we also have the team of researchers, staff who support this incredible thing that we do. And so I'm going to introduce you to the first of those, and we'll go through some things about valve disease we'd like to share with you. And that person, to start off, is Dr. Nadira Hamid. Dr. Hamid is not originally from Minnesota, and she has moved west in her career as she's come about, originally from Singapore. Did state-of-the-art training in New York, where she did an extra year because she just didn't want to go work yet. And so she's one of these imagers who is my eyes and ears. And we're going to talk about how valve treatments are done, but she tells me where to do things, where to put devices, how to treat patients, and I cannot do anything without her eyes and ears to tell me what to do. And she's going to talk to you about valve heart disease basics. So Nadira, please welcome.
Is there the clicker? Oh, okay. Well, good afternoon, everyone. As Paul has introduced me very nicely, thank you. My name is Nadira Hamid, and I am, like he said, his eyes, including Dr. Itura's eyes as well, as they do procedures in the cath lab and also in the surgery. So my specialty is in imaging, and a subspecialty of it is really guiding the procedures for Dr. Saraja and team, and also as the surgery as well. And as all of you have known, today is Heart Valve Awareness Day, February 22nd. And the key thing about it is this is really a public crisis, just like any other disease, cancer, or any other comorbidities as well. The heart valve disease is truly a public crisis, and that's why we have a special day like this. And really understanding about the heart valve, right? Before Dr. Itura and Dr. Saraja take you through more about the procedures and innovation that we do. So if you look at the diagram on my slides here, so the heart, you have 4 chambers, 2 chambers on the top and 2 chambers at the bottom. And you have the left and the right-hand side. The right-hand side, you have the chamber on the top, which is the right atrium, and then you have the chamber at the bottom, the right ventricle. And the key thing is you have 2 valves on the right-hand side. You have the pulmonary valve and you have the tricuspid valve. On the left-hand side, you have the chamber on the top, left atrium, and the bottom chamber, the left ventricle. The 2 chambers on the right-hand side, as I mentioned, the pulmonary and the tricuspid valve is something what me and Dr. Saraja have worked on for the last 5-6 years, which he'll take you through. It's one of my favorite valves. And the most important, it is, and he'll take you the procedures that we have done and really the trials that we have both pioneered for the last 6 years. And the blood flows from the right-hand side out into the pulmonary and then goes to the left side and goes to the pulmonary valve, the lungs basically, to get oxygenated. And then it goes to the left part of the heart and then it pumps out all the way out through the aortic valve, just like, you know, Gloria was mentioned, the aortic valve. And the mitral valve is also on the it's on the left-hand side. So you have 2 valves on the left and 2 valves on the right-hand side. We also specialize in the aortic valve and the mitral valve, as Dr. Itura and Dr. Saraja will go through with you. But the most important thing about these 4 valves is that you can get disease. Look at the left-hand side, the picture of the aortic valve. That's a normal valve. The leaflets are, it's fine. It's moving very well. And when it gets disease, it gets two types of disease. You can get stenosis, which means that you can get calcium around it. It doesn't open very well. And the other problem that what Gloria, our patient, had was the leaky valve, where instead of the blood going forward, it goes backwards. And a problem with the blood going backwards, you get congestion and you got all these symptoms, which I'll take you through in the next couple of slides. The key thing is, what is the prevalence of valvular heart disease in this country or in the world? As you can see, that all these 4 valves can get disease, and most of these disease valves usually occur as we grow older, and it's part of the natural process, including hopefully when I get old, hopefully someone will take care of me. But as you can see, it's usually more than 55 years old. And in this country itself, guess how many people actually have valvular heart disease? I mean, it's really astonishing as they did studies on this. It's actually more than 5 million in the United States alone. As we all get older, we will get some form of heart valve disease. Now, the key thing is there any sexual differences between men and women in valvular heart disease? The answer is yes. As you can see in this paper and this central illustration, this diagram showed there are differences from a scientific and anatomical differences in all the valve disease, in the 4 valve disease. But the key thing about what's different between men and women, and we women, present these cases very late. I like to think that we women are more resilient. Like what, in the British would say, we are kind of a tough cookie. So we tend to present these symptoms very late compared to men, as studies have shown all around the country. In addition to that, you have differences in the anatomy and underrepresentation of women in clinical trials. And I'm very proud to say that in Minneapolis Heart Institute, we are the first in the United States to be participating in a woman heart registry, which I'm actually leading it in collaboration with our European colleagues. So really appreciate all the support that you have. That we're learning more about valvular heart disease in women. So more to come into you in the next couple of years or maybe next year. But the thing is, you look at this image, what has the worst survival in terms of outcomes besides cancer? Actually, valvular heart disease do have the worst survival as compared to breast cancer and prostate cancer. And the key thing is that besides it being malignant, you have a lot of treatment options for it. Multiple options in terms of repair, replacement, and all the innovative treatments that we are doing in MHIF, as Dr. Sraja will take you through the slides. The symptoms-wise, as I mentioned earlier, a lot of symptoms, you just feel not right, palpitation, chest pain, or any symptoms, please go to your primary care who will refer you to us, or we can just come up to us, to our primary cardiologist, to look after you, because you want to prevent the deterioration of the symptoms where you have weakening of the heart muscles, you have congestion, you have heart failure symptoms, your leg swelling, difficulty breathing, and most importantly, as we learn from the studies in the tricuspid, your quality of life really has impaired, and we want you to have a good life. What's life without living? Spending time with your kids and your grandkids. And so in terms of the options of therapy that Dr. Tura and Dr. Sraja will take you through, there's many. From a surgical option, you have the open surgery, we have the advanced therapies such as mini surgery where you have little scars. You have the transcatheter options through the legs and groins, which really has revolutionized how we do valvular heart disease right now, because they get to go home really the next day. And multiple devices, which I'm fortunate to be involved in many of this, where we can do this through the groin or even open heart surgery. And really, like what Dr. Sraja said, it's a multidisciplinary team approach where we will go through all the imaging with our surgeon, our interventionist, and our imaging to decide what is best treatment for you, really for the durability so that you don't have to go through another procedure. And that's what Dr. Tur will talk to you about. In terms of the number of valvular heart disease that really get treated, nowadays you can see it's really very little. Less than 1/3 of the patients, of these patients that present to us are treated. So even coming to us within our healthcare system, it is also an issue as well. So we as healthcare providers are doing actively with societies to make sure that these patients are not only follow up, that they get the accurate treatment early before they get worse. So this is a video of patient of Dr. Suraja. Imagine 3 months after treatment from a mitral clip through the groin, he is doing water skiing down here in the Lake Minnetonka. So, these are the things that we do that really help in the quality of life for these patients. Not at this time, but certainly during the summer for water skiing. And this is something that I really am gratified, and this is why I do what I do. For patients like this patient of ours that Dr. Suraja knows, it's a patient that we did a Badman procedure. So we are trying to put a valve through the mitral valve and creating room between the two valves in the left-hand side, the mitral and the aortic valve. So it's an innovative procedure, and this was the first patient that we did. Truly, and you can see on the left-hand side, post-procedure, I think Dr. Suraja mentioned that she loves to go skating, and he and the team, we bought them roller skates for her so that she can, the next couple of weeks go roller skating, after the procedure. And I believe Dr. Suraja, she's doing very well. Yes. So, this is why I do what I do, really seeing patients like this, getting that quality of life and spending time with their family. And before I end, just a couple of heart valve disease facts. Really, the prognosis, think about heart valve disease, it's like cancer. You have effective treatments available, which the two next speakers will talk to you about. Most importantly, it is a public crisis. Most people are not treated, and 3 in 4 people are not aware, and we can certainly do a whole lot better. And having things like this, symposiums and raising awareness is truly remarkable. What can you do as well? Keep learning, spread the word, a couple of join the groups you have on social media as well, getting the word out and helping support us at MHIF. With that, thank you very much. And without further ado, I would love to introduce my next speaker, my surgical colleague, Dr. Itura, who will take you through more about the lifetime duration of the valves.
Good afternoon, everyone. So thank you for the invitation, and thank you for having the opportunity to talk to you. I'm Sebastian Itura. I'm going to talk about lifetime management of valvular disease. So I have no personal disclosures, but one thing is that I'm a cardiac surgeon. I do love what I do. I do believe we can help a lot of patients, but I also did a structural fellowship, which means try to be less invasive, because I think if we can do the same kind of procedure, being less aggressive, it should always be the first option. So cardiac anatomy, Nadira went a lot through it. Basically, we're 4 valves, but we're going to try to focus to lifetime management just to one valve, the aortic valve, to try to simplify how we understand it. But this is, it relates to all other 4 valves as well. And we're going to talk about aortic stenosis, which is the narrowing of this aortic valve. Now, when we talk about how heart valve has been disease has been treated, it has been historically been treated with surgery. And why? Because it has been proven that it improves quality of life, but also it prolongs more lifetime years. And so far, for decades since cardiac surgery has been existing, a lot of patients do get that procedure done. But we also know that cardiac surgery is an invasive procedure, and the recovery time is not the same on everyone. It's not the same having surgery when you're 20, when you're 60 versus you're 80. The older we get, it's a bigger impact on the body itself, so we know that recovery is tougher. Since the beginning of cardiac surgery in the mid-1950s, there's been a lot of progress, a lot of evolution of how we treat, how we develop these valves. And until now, which is the transcatheter, which is the final step, and also with the mechanical valve, there's also been a lot of evolution, a lot of improvement in the valves. Now, when we say about this is very important principles, if we would pick a tissue valve, they will always degenerate. And it's the same thing as our normal valve. If we all lived 200 years, our valves will never be able to live that long. With time, with aging, the valves tend to deteriorate. They tend to get more calcified. With the biological valves that we put in there, that deterioration tends to be faster. It's always hard because we get the question, how long would these tissue valves last? And it's a little uncertain because it varies from patient to patient. Some patients may have deterioration or basically damage of that valve between 2 years. Some may last 30 years. We know that the average is around 10 to 15, independently of which kind of tissue valves we pick. On the other side, if we pick mechanical valves, which is the other option to replace when we have to change a valve, is that we have to necessarily take Coumadin, which is the old traditional anticoagulation. There have been a lot of trials to try to use the newer ones, Xarelto or Eliquis, and they have not been able to be compatible. So if you need a mechanical valve, as of today, we have to take Coumadin. And overall, we know that Coumadin has a lot of downside taking that medication. So as a normal society, we try to hopefully avoid taking Coumadin if we can. But again, if you take a mechanical valve, it's something that you have to take. And why is Coumadin not ideal? Mechanical valves are not ideal because the longer we live, the more potential risk of complications. Either it could be bleeding because of the same medication, or it can be a thrombotic that have a coagulation secondary to those valves. Now, this is a recent study, and I'll promise try not to be too technical, too specific, so we can all understand what we're saying. But overall, if you're young, and young is a very relative concept because young is different. I was young probably 10, 20 years ago. But usually the younger we are, we tend to more inclined to take mechanical prosthesis because, again, they will last longer. They won't have this deterioration. And it's been proven around to 60, 65 years being a reasonable cutoff. If you're younger than that, maybe a mechanical valve will help make you live longer than if you pick a tissue valve. I just want to have one slide about this. There's an additional procedure. If you're young and you're in a center that has multiple intervention, you could do a Ross procedure, which is another alternative of using mechanical or tissue valves. Now, nowadays, this whole paradigm is changing to, one, try to give us as a medical society as much information to the patient so the patient can make a decision as informed to know what's expected or what he expects for his lifetime management. Now, when we talk about the aortic valve, we have these two main treatments. One is going to call SAVR, which means surgical aortic valve replacement, versus the other one we're going to call TAVR, which is transaortic valve replacement, which means basically not an open cut and going through the groin. And which option is better has multiple factors, and we're going to try to summarize it so we can all understand how to proceed. But one of the first things is to share decision, how much information we can give, how much a patient can understand, and finally be part of this decision making. But one of those factors is age, as we talked. The younger, we should probably more favor surgery than TAVR. Also, medical condition. It's not the same, for example, a patient who is 60 versus someone who's 80, but it's not the same if you're 60 on dialysis, someone who's 80 that comes walking to clinic or comes in a wheelchair. So there's multiple factors that age is a factor, but also all these other medical conditions to it. And one important thing, if you have a suitable anatomy for TAVR. So we have to try to introduce this device to the groin. So you have to have a very good adequate artery to be able to introduce. And also in the heart to have a very good anatomy to be able to place this valve in there. So when we think about surgery versus TAVR, important consideration. If you have a lot of coronary disease, which is another problem in the heart, when you have poor irrigation to your heart because of coronary disease, there are patients that maybe benefit more from this combined thing that we can do with surgery versus TAVR. Also, if you have an aneurysm, which is something that tends to associate, especially when you have bicuspid aortic valve, it's something that more tends to go towards surgery than TAVR. When you have multiple valves, they can be eventually treated through catheters, but multiple valves are also things that can be done at the same time if we do an open heart procedure. And atrial fibrillation is another thing that we can eventually consider to be treated at the same time of open heart surgery. So when we try to compare these two big therapies, as we said, surgery or SAVR means an incision. It means to be in general anesthesia. We're going to talk a lot about it, but it also means on a heart-lung machine. That is the only way to be able to do the surgery. It means a hospital stay around a week, and initial recovery, which varies from patient to patient, but let's say it's about a month until you have to feel good, back to healthy again. Versus TAVR, which is no incision, it's just a puncture. It's just sedation, doesn't necessarily be requiring general anesthesia. It does not need a heart-lung machine. It's a shorter hospital stay. Some people may even stay a day or less in the hospital, but where definitely TAVR wins every time is on a faster recovery. We're talking about a month versus a couple of days until you start feeling back again. And Dr. Hamid showed one of the videos of a patient it's not, you wouldn't think that a patient would be skating or going on a fishing, whatever, less than a month of the procedure. Now, with surgery, we have made a lot of improvement too. And Nadia mentioned all about it. But to do open heart surgery, you have to try to get inside. And there's a lot of ways where what traditionally was done to do was an open sternotomy, basically open this bone fully. Nowadays, when it's just an aortic valve, I think most of the procedures can be done less invasive meaning open only half of the sternum. It means a faster recovery, but again, it's not comparable to what TAVR can actually offer. Now, when we do open heart surgery, it's a very standard procedure. We have to get inside. We have to connect the heart to the heart-lung machine. We have to take out the aortic valve and put a new prosthesis, which can be mechanical or tissue. And that's another difference compared to TAVR, because TAVR is only tissue valve so far. So this is a video in the OR. Actually, one of my partners recorded this. There won't be no patient from minimal blood, so we can have the same, between the lunch thing now. But the video shows that there's basically a lot of people in the OR, and there's a lot of team to try to make it as safe as we can. There's the surgeons, the people that help them. There's an anesthesiologist. This is the heart-lung machine. What it does is basically take the blood out and put it back in with oxygenation and pressure. That's why we're able to not need the lungs, and that's the way we actually do every heart surgery that we do nowadays. Compared to the cath lab, which is something similar, there's just pictures, there's no videos, which is probably about the same space. It's not as crowded as an OR, and usually the heart-lung machine is not there. And in the cath lab, this is what we're able to do. There's two main commercially available valves available for TAVRs, but it's a procedure through the groin, and through the groin, you're able to advance, navigate into your aorta, and go into the valve, and just place this valve. Either it can self-expand or balloon expand it according to which valve actually is needed. But you can imagine it's a procedure that actually can be said that only with local sedation. It's only a puncture, and eventually can be discharged the following day if everything goes well. One of the differences that you do not take the aortic valve as we do a surgery, which is one of the different things that eventually could happen afterwards. So we tend to do everything as a medical society based on guidelines. These are the last guidelines that we have by the American Heart Association, which is from 2020. And it tends to recommend that patients below age of 65, they should be probably considered for surgery. On the other extreme of age, when you're above 80, they should probably be considered for TAVR, this transcutaneous approach, because of all these reasons of the recovery afterwards. In between, it gives a big gap of patients. That is where all this decision-making information to try to see what's the best approach for you. Now, same with the TAVR, and I mentioned it before, it's all about the pre-procedural planning to make sure it's a successful implant. And pre-procedural planning is based on two tests, which one is the echocardiogram, and the other one's the CT analysis. And with that, we can make sure that you're a good candidate and eventually you're a good fit for having hopefully no complications related to it. And that's why we meet every Thursday, and this when we say we meet is a group of teams between the cardiology, interventional cardiologists like Dr. Suraja, imaging doctors like Dr. Hamid, cardiac surgery like myself. There's a research team, there are coordinators, and we try to figure out which is the best approach for each individual patient. So we meet, we talk about 20, 30 patients, and we review all their history, all their images to make sure that when we try to make a recommendation to be a group, the team, and not a personal decision. Now with TAVR, there's a lot of tests, a lot of trials, a lot of very specific populations, but so far they all have shown very similar results, that is as good or maybe sometimes even better than surgery when we target those specific population. And that means also the more it has been done, the more or less chances of getting more complications because you get better at it, you have more expertise to it. And that means that the numbers of TAVRs have gone really up. So the yellow line that you can see, or kind of orange line, the numbers of TAVRs have been increasing year by year, and the numbers of surgery with the time has also been decreasing too. But it's also important, and this is not to criticize other centers, because other centers obviously are independent, but the increase has been significant on patients that are younger, less than 65, which with our guidelines, they're usually patients that are recommended more for surgery. Why? Because we don't know yet how long these TAVR valves will last. They're tissue valves. As any tissue valves, they will degenerate with time. We don't know if that will happen in the 5, 10, 15-year range. And also, the other important thing, because the younger you are, it's more likely they have bicuspid valve. It's just a little complicated concept, but the aortic valve normally is supposed to be like 3 little doors. That's what's called tricuspid aortic valve. And it's not a malformation, but it's a variation that people may have 2 doors instead of 3. And those 2 doors, the bicuspid valve, means that the valves are more calcified. They tend to have more problems in early ages, so it's a younger population. And it's not that TAVR cannot be done, but it's a little more challenging of a TAVR. And usually these are the younger population that sometimes we think that surgery may benefit more than from TAVR itself. Now, what do you do if you have a tissue valve? You were placed, for example, at 50 years of age. You got good 15 years, you're 65. What do you do with that valve if it goes down? And we're going to be faced as a team that we have 2 options. Thinking about redo surgery, which definitely can be done. It's a little more challenging to get back inside, but it's something that we are faced a couple times a week, versus thinking of doing a TAVR inside that valve, what we call a valve-in-valve. And there's a lot of studies, but basically, as we all know now, that TAVR is less risky, it's less aggressive. But one of the problems that we face with TAVR is this, when we put a valve inside the valve. So we already have a valve, we're going to put another valve, so this Russian doll effect that we're going to start using more or keep up utilizing this space, and eventually going to have a narrow with it. So it's one of the things that we have to consider as a team to make sure that if it's a good fit to be either options when your valve fails. And also now that a lot of patients are getting TAVRs, and you saw that line, that curve that keeps going up, we're going to be facing more and more that this TAVR starts failing. And as a surgical society, it's the fastest growing surgery for all of us. At the beginning, it was a high-risk procedure, but now with more surgeries that we've been exposed, we're getting better at it, and the surgery's results have definitely improved. So if you have a TAVR, you can also think about putting a TAVR inside a TAVR, a TAV-in-TAV, what we call. And it seems a very simple procedure, and actually it is compared to taking that out as a surgical ones, but we cannot offer it to everyone. For example, you have infection, you cannot do it because you have to take out the infection. You also have to be very concerned because I don't want to be too technical, but the arteries of the heart are very close to this, so you can eventually obstruct the arteries when you put it in there. And one of the other problems is also we're going to start facing this, that we're going to have another valve inside a valve, and we're going to start compromising a space that is limited. For that, there's a special app, and actually it was designed by our team that is used for many other centers in the country and worldwide to try to figure out if you're a good fit for this TAV-in-TAV procedure. Now, to try to summarize it, I think it's the most complex slide of all, is that there's a lot of alternatives. And that a lot of alternatives can be either, as we said, a Ross procedure. If you're really young in age, you can go for a surgical mechanical valve, which is something that probably will be a one-time procedure. You can go for either a SAVR, which is a surgical tissue valve, and then consider another surgery in the future, or get a TAVR in that. So there's multiple options. That definitely doesn't make it simple for us, and I understand it will make it more complicated for you, for patients that are not routinely done with this. And again, this is all based to how we can help you out, and I put this picture back again, which is this valve conference that we have every Thursday, that we discuss every patient for every kind of condition to make sure that we hopefully recommend the best option for you all. So as a conclusion, so we have these 2 big options, but it's all about lifetime management. And it's not as simple as just to put it as age as the only factor. I think we have to consider all. And this is the multidisciplinary approach to try to make the best, I'll give you the best recommendation for you all. Thank you very much. So just want to remind you all that we have these questions at the end of the session. So if you can write it down, we'll answer. And welcome back, Dr. Soraya.
Thank you. Thank you, Sebastian. Wonderful, wonderful overview. And that was a whirlwind of treatments to go through. A lot of science in there and a lot of nuance. And we'll have plenty of time for a question and answer. So if there are things that weren't clear, please write them down, and we'll take our time at the end of this part to talk about them. So I have the pleasure of talking more about our foundation and the research, and do a little bragging. So I'm going to tell you a little bit about what we do in more detail. But as Nadir mentioned, we're here because we do feel that valve disease is a public health crisis, and that's why there is this National Valve Heart Disease Awareness Day, which happens to be today. And so that's why we're here. And as she mentioned, when you think about the campaigns that are out there, you know, we all have campaigns for the various cancers, and breast cancer, prostate cancer, and when we think about valve disease, there really is not as much awareness because it just doesn't quite call the attention, and it's no fault of anyone. It doesn't have the young group of patients that may feel more tragic, but that doesn't mean it's any less tragic in our view. Patients who have valve disease deserve to be treated. And when you look at this and you think about the importance of valve disease, as Nadira mentioned, there are 5 million people in the United States alone, more than twice or 3 times that around the world. And most of these patients, unfortunately, are not getting treated. And, you know, and unlike other cancers, you know, or other life-threatening conditions where it may be chemotherapy, it may be high-risk surgery with an uncertain benefit, with valve disease, as Sebastian showed, one of his surgeries will save the life, and it is a life-saving procedure. And so that's why we feel very strongly. It's an easy story to tell from our standpoint. So I want to tell you that a little bit about who we are, and we started with that idea that we just want to reach more patients with what we want to do from a research and investigational standpoint. And so in 2016, we actually founded our Valve Science Center. This is a younger picture of me back then, and we started with this whiteboard. Roger and Lynn Hedrick, who you may know, they have been members of this community for decades. They gave the seed money to start this center. And we have been very fortunate to be able to recruit, as Rebecca mentioned, an incredible team. I have the luxury of working with these experts who are celebrities, all in their own right. They're celebrities from around the world. If you go to these scientific meetings, the water parts whenever Vinny, Joao, or Nadira walk in the room. It's really amazing. And with that, we've been able to do a lot of first-in-human things. There's a list of these first-in-human accomplishments, many therapies that were done first time in the world at our center. All of you are here at least today. I don't know how many of you are here permanent residents or how many are from Minnesota, but we have the luxury of living in Minnesota where there are over 300 med tech device companies. A lot of them are inventing just amazing stuff, and being close to these companies, we're able to do this through our foundation and deliver these therapies. And so it's been incredible. And with that, I'm going to share an example of how this starts with a patient who may be you, and then leads to a treatment. So a couple years ago, I had the privilege of giving the groundbreaking results of the first trial called Triluminate that focused on tricuspid therapy, tricuspid repair. And this was at the American College meeting. This is a picture of our group. And so, but what's not often known is the story behind that. And so this is a story that started with a patient who in 2015 in the fall, we had tried to take a MitraClip thing and MacGyver it and use it for the tricuspid, so off-label MacGyvering type thing. Well, we failed, and it was not successful. He managed to live for a couple more months, but in that time that he continued to live, he said, we became good friends. He said, Paul, you got to fix this. And I was like, yeah, we do. And so I went to the company, Abbott, and I said, what can we do to help? And the patient and his family graciously gave us a 3D print of his heart. And we used that 3D print to then design devices. And that 3D print is still the same 3D model that's used to train physicians on this device 8 years later. And so we called for help, and you can see this is actually the 3D print of his heart. You see there on the left-hand side? That's actually the model is set up, and we tested all these different devices to see how the steering would work. And then we did the first case in the world with a new purpose-built device in 2017, the very first one. And then we started a clinical trial. Our site, because of our position, was the top enroller in this trial. And then this device was approved last year. And now it's being used in tens of thousands of people worldwide already. And it's it's amazing how it all started with patient need. And that's why days like today, with all of you being here and understanding the importance of valve disease and help us understand how we can help you, this is why we're here. This is why our foundation exists. And so it's a real privileged position. And this is an example, not the first patient who complained, but a more recent patient who talks about how much she loves her skinny legs. And her legs got skinny because of this treatment. Isn't that pretty neat? So you know, because patients with heart failures, you may know, can get swelling in the legs, and hers got better when we treated. So it's an example of how things can start, and really what may seem like a small impression can really reach people around the world. And people come from all over the world to come study with us. We have an amazing scholar program. They come and do research with us. We've been able to share these people, and they go back to their home countries learning from us. We have the ability, as Rebecca mentioned, to publish and do presentations. And this is an audience where we did a late-breaking trial presentation. In the middle there, if you see me, I have a miniature version of myself in scrubs. That's us doing a live case that's being transmitted around the world. And then, as Sebastian mentioned, we've gone digital. We have applications in the digital world. These have been downloaded hundreds of thousands of times. And the amazing thing is that they were created by Vinny Bapat and his colleagues in our foundation, and they're all free. And what these are used for is they're used to plan lifetime management of our patients' treatments. And they're so free and so popular that it's actually considered malpractice not to consider these before planning these therapies. And they appear all over. And it's just fantastic. So we do this event each year, and I want to thank you for being here. It is important for us to be able to share what we do with you all. We feel very passionate about it. I hope that comes obvious to you all. And I want to thank you all. So with that, we're going to move into the Q&A. So if you haven't submitted your questions yet, I want to invite Nadira and Sebastian back up here, please. And then I'll moderate a quick Q&A. Thank you.
Thank you. Oh, yes. Okay.
Awesome. Okay. Love this. Thank you. Please have a seat.
Okay.
Thank you. Okay, we got a lot to talk about. But this is fantastic. Oh, this is actually okay. I love this first one. So first question, Sebastian, for you. This is related to Gloria and her story. How does radiation therapy play a role in deciding SAVR versus TAVR? Tell us about radiation risk if somebody has radiation to their chest and their surgical options.
So radiation, it's always a little unknown what's going to be happening inside. We know that radiation has changed a lot, like evolution of medicine, so it's a different from the cobalt that was received from the video that we saw versus the radiation we get today. It's a little more localized, a little more focal, but it's still unknown. When we go, we try to predict how things can be inside, and that's why we tend to get imaging from CT and echocardiogram to see how much eventually damage can be caused by the radiation. And that's because the radiation, for example, for a focal breast cancer, it's really hard to be focal to only the breast. It hits everything that goes in between the way. If there's too much, for example, calcification, we think that patients may benefit for being less aggressive, and that's where interventional can come into place. But also, when we have multivalvular disease, we know that probably surgery is more fit for that kind of situation.
Great. So both options are considered. Definitely. For sure. Okay. Nadira, how do you determine what's severe in terms of severe valve disease? Severe calcification, if somebody has an ablation or something in the heart, does that affect things like catheter-based ablation for arrhythmia or such? If somebody's been in there, does that affect the valves? Yeah.
That's a great question. It shouldn't, because you're trying to stay away from the valves, especially for catheter ablation for atrial fibrillation. And to the first question on how severe do we do it, and to Dr. Itura mentioned on the slide that we do echocardiography as kind of the first line, in the assessment of any patients referred to us in the valve clinic, or even in primary care as well. When they hear a murmur, and echocardiography is kind of the first line where we see the heart structures, the 4 chambers, and all the 4 valves. So it is, I love echo. That's what I do every day. And really from the echocardiogram, we do a lot of, measurements thoroughly to assess the severity of the valves, whether is it aortic, mitral, the tricuspid, is it stenotic, is it tight, or is it leaky? And there's a lot of parameters. These are all guideline-based with the American Society of Echo. And if there's any inclination to the severity, whether is it, a little severe or, to determine it, we do additional imaging as well, like CT, to really confirm that. But really, echocardiography is the first line to assess the severity.
Sometimes we get the calcium score off CT, because that can tell us, like an X-ray, how things are calcified as well, too.
That's right. And, to your point, to my slide about women and men, the differences in aortic stenosis, we women actually get less calcium, and it's really the fibrosis of the leaflets. And so we see a lot in our valve readings that, we get the gradients very high, it's really stenotic, and the calcium score may not be as high as men. And this is all through the studies in the last couple of years through various institutions, including us, understanding the differences between men and women for aortic stenosis.
Another question was, do we receive any government funding? If we have research grants through the National Institutes of Health, we would, but otherwise we do not. And so our foundation is otherwise not supported that way. Let's see. Sebastian, for a patient with a bicuspid aortic valve, an ascending aorta of around 44, 45, how do you describe the option to treat both the aortic valve and aorta at the same time? What do you do for them, surgery?
Sure. Yesterday I had to be in Rock the Heart, and we actually talk about this ascending aorta, when it becomes a problem or not. So I think they have to be divided in 2 problems, and if we have aortic stenosis, that should be treated. The ascending aorta, when it becomes an aneurysm, there's a risk of rupture, and the rupture can be a very serious, complicated event. And we know that the rupture, it has a lot of parameters, but one of the biggest ones to predict the risk is regards size. And size, it's a little hard to be a specific number, but usually when it's about 50 to 55 by itself, it should be treated surgically to prevent a complication. If it's less than 40 to 45, you can just leave it alone. The question is, if you go to the OR for a patient, for example, to replace the aortic valve, what do you do at the same time with the ascending aorta? And this is because we think we have a one-time opportunity to do a lot of things and hopefully not have to come back, because the aorta grew in the following 1 year to 2. So between 40 to 45, I think the threshold is kind of low to treat both of things at the same time. So do an aortic valve replacement and do an ascending aorta replacement to try to prevent future complications. And in this kind of situation, it can also be done through only a partial sternotomy, which I think recovery, definitely, it's better if you be less aggressive with intervention.
I have 2 quick questions from me I can do real quick. So what is important of dental clearance? That's a really great question. It's extremely important. And so every time we brush our teeth, we're introducing bacteria into our bloodstream. And if we have a fresh valve that had just been put in, that fresh valve can easily get infected. And so we always insist on patients having good dental health as best they can before any procedure, whether it's surgery or transcatheter. And then we also ask you to abstain from dental work for 6 months afterwards, so that valve can be covered, and you can have safe introduction of dental work thereafter. Okay. And then the second quick question was, can I do an aortic valve replacement through the neck? You can. So TAVR can go through the carotid artery. But that's our second choice because arteries through the groins are more customary. We use your legs like a table, and so all the catheter equipment is down here. When we're up at the neck, we have to have multiple people holding things, and it's a little bit more challenging. But we'll go through the neck if needed. Nadir, a question for you. Mitral valve repair. How often do you do echoes after somebody's had mitral valve repair? And then maybe Sebastian, you can answer, how long does a mitral ring repair last? Nadir, do you want to go first?
Yeah, absolutely. So the mitral valve repair, obviously after the procedure, we'll do it before you get discharged, and certainly within the first year during your clinic appointment. And I tend to do the echocardiogram once a year for my patients, although the guidelines may say actually longer, right, Sebastian? But I tend to do it at least once a year, just to make sure that the valve structure is functioning well, whether is it a ring or is it a replacement. We do all the parameters on echocardiogram, but at least once a year.
When you have mitral regurgitation or mitral insufficiency and you have an indication to go to surgery, there's two things that we can do, either repair or replace the valve. There's a lot of evidence that repairing the valve could be better for the long-term results, so that's why that's the first approach to try repair. But I think the secret is to be able to repair and make a good job repairing it. So we have different degrees of how to classify that, if it's a mild regurgitation, moderate, severe after the procedure. If we, for any reason, surgically leave a moderate or mild to moderate regurgitation, that chance of failing in the future is much higher because you already start with that low thing. So if you're able to actually get a very good repair, meaning no regurg after it, the chances of having residual or intervention in the future actually is very low. So I think it's all about how good of a job you can do it. And as of a surgery, if we had a conversation, if I would tell them, if we're not able to have a good repair in the OR, it's better to replace that valve than to have a not as great and have a chance of having to come back later in life.
I think, when valves are leaky, they can become leaky again. And that's the easy way of putting it, as Sebastian described, whether it's surgery or transcatheter. From a transcatheter standpoint, I usually tell patients after we do a transcatheter repair that the risk is around 1 to 3% in the first 6 months that you could have a need for another repair, and probably about 5% or so over the lifetime. And so these valves can leak again, and sometimes they just need to be re-repaired. And so those are things that are very possible. Sebastian, what do you prescribe for anticoagulation after SAVR or aortic valve surgery?
Sure.
Do you do baby aspirin? Do patients have to take Coumadin? Maybe you could talk about aortic and mitral.
Sure, so I think both approaches are kind of similar. So first, if it's a mechanical valve, we talked that it has to be Coumadin. There's no way to avoid the medication. If you pick a tissue valve, so a different way to approach it, I think lifetime management with aspirin is a must for both valves. When you go for aortic, it varies from center to centers. At least locally, we don't give anticoagulation after a tissue valve. Some groups may give us anticoagulation for a month. With a mitral valve, since it's a little more, be more thrombotic, you can have more chance of having clots, we tend to give anticoagulation for the first couple of months. And then it's just aspirin by itself.
And the risk of aspirin, what do you normally tell people?
It's a baby aspirin. It's 81 milligrams. So, I mean, it helps you have a little more longer times to actually form a clot, but the side effects are very minimal. The side effects regards bleeding or having GI complications, gastrointestinal complications, are very low.
Yeah, about 1% per year. So it's not that it can't happen, but it's very, very low. But it's important to reduce the risk of a stroke that can happen on these valves after the procedure. Nadir, several questions on valve and valve. So when you see an increase in the gradient for a valve that's been, I should say, this is about degenerated prosthesis. When you see an increase in the gradient, what are the triggers to think about either a redo surgery or a valve and valve? What are you looking for in the echo?
Good question. So the echo gives me a real inclination, and I always put in my reports, to be referred for the valve consults. But the echo, you will see the increased gradients One thing as well on echocardiogram, we can see the mechanism of why you have that failed valve. Is it a leaky valve or is it stenotic? So we can see the leakiness around the valve as well or within the valve as well. And so within the valve is because the leaflets within it has degenerated for some reason over a period of time. How long is very hard to tell. I've seen it, almost less than a year, more than 5 years, or 10 years. So we have seen a huge range of it. And that's why, there's a lot of work in terms of trying to get the durability of this valve as long as possible. In echo as well, we can see not only the mechanism, the increased gradient, and to see what kind of therapy. It really varies as well. We would then perform what we call a transesophageal echo, which is basically the ultrasound and echocardiogram through the food pipe. So to have a better visualization of what kind of therapy, whether is it, open heart surgery or another percutaneous options, and then in addition to the transesophageal echo, doing a CT as well to plan for which therapy, and then we'll discuss at our valvular heart meeting on Thursday to see what therapy is best for the patient.
But you would agree that the severity criteria for a prosthesis is the same as for a native valve?
100%.
Yeah.
Absolutely.
So we look at whether you have had your valve replaced or we're looking at the valve you're born with. We use the same criteria to judge whether that valve is leaky or narrow. Is that a fair assessment?
Absolutely.
Yeah, and then that helps trigger the indications for treatment, which are also driven by your symptoms as well as if there's any evidence of heart failure or heart enlargement. How about Coumadin? Sometimes when we see valves that have been put in, they start to wear out. Can you describe a little bit about Coumadin and why we do that?
Yeah, no. That's why we do the echo at least once a year. If there's increased gradient, we'll do we'll find out why. And if we see there's some, small clots or thrombus around the leaflets, we can actually resolve it with Coumadin for a short period of time. So that's why, doing this echocardiogram at least once a year gives us an idea before it gets worse. And treatment with Coumadin may not be long-term, just a short-term, just to resolve the presence of thrombus around these valves.
And the question that was just posed to me was, why not Eliquis? And Eliquis is different from Coumadin because they act through different tissue pathways. So we have tried to use Eliquis to treat clots or treat valve disease, but it doesn't work. The biochemistry is just not there. And that's as much biochemistry as I'm about to tell you. So, okay, so that's the end of that. Okay. Let's see here. How does Nadira, can you describe a little bit about how the clip works? So there was a brief discussion about clip and on my slides and others. Can you tell us a little bit about clip for mitral tricuspid?
Yeah, my favorite.
Okay.
So basically, it's literally like a clip. So it has two arms like this. And I will guide Dr. Saraja as he goes through. So for the mitral, like Gloria's video where we puncture a hole between the right chamber and the left chamber, we'll puncture that across with guidance with echocardiogram, which is me, and then guiding him as he goes down into the leaflets. With echocardiogram during the procedure, what I will tell Dr. Saraja, where's the leak? Where can we go with the clip? So I will guide him using 3D. So with echocardiogram, technology has advanced a lot that we can use 3D with the echo, guiding with precision to the exact spot of where the leak is. And then basically with these two arms below the leaflet, we will grab the leaflets and closing it together, bringing the bridge of the leaflets together. And then using on echo, I will see that there is basically regression of the leakiness of the valve. So we do this not only on the left side, which is the mitral, but also on the right side, which is the tricuspid, valve 2. So really for these two procedures, am I safe to say that really echocardiogram really guides these two procedures with precision, and really with the technology of echocardiogram right now, we can do these procedures in less than 1 hour.
I can't do it without you, is what you're trying to say.
Oh,
Yes.
I mean,
She's being very humble.
No.
Yes. And the other thing, the clip is the most sophisticated stapler you'll ever meet. I should have brought one, but maybe next year. But it's incredible how it puts the leaflets back together.
Yes, and then we have also not only the clip, we have also the other clip, you know, the Edwards, the Pascal as well, that does the same thing with really reducing. They have different features, right, Paul? And so really help to reduce that leakiness of both the mitral and the tricuspid. So we have various options and devices.
And insurance does pay for both,
right.
as it also pays for research studies. So that's often a question that people ask. Insurance does cover research studies. And so, in fact, I'll say insurance covers research studies better than most commercial studies. So if you're on Medicare Advantage, sometimes you might have run into issues with commercial coverage. But Medicare Advantage actually covers research studies very well. So, Sebastian, one question, it was actually a really good one. If your first valve lasts 15 years, will the second valve last just as long or longer? Or is there differences in duration depending on your age? How does age affect the duration of tissue valves?
Sure. So I think it's always unpredictable. So no one can promise you, and that's one of the mistakes I think probably a lot of us make, that say if you get this valve, you're going to get 15 years. I think it's very variable from patient to patient, and also because how well or what age you are. For example, if you're on pregnancy age, probably those tissue valves won't last that long because the pregnancy, how much flows there goes, there may be deterioration faster. Same thing happens, for example, patients that are on dialysis. Because of all the problems with calcium, they can get calcified before no. I mean, if you think logically, I think there's a good chance that valve will last very long. If you have a tissue valve, maybe it'll last the same 10 to 15 years. But the concept is you cannot promise that to anyone.
There are a few questions about our research enterprise. So we see there's discussion about 3,000 patients. How many of them are research? It's the minority. Less than 10% are research. And then there was a question on, let's see, what if I have a slow closing valve on the left side? And so I think that may mean that your valve is not opening as well. And so typically a valve either has problems with opening or has problems with closing. And if the valve can't close very well, it could be very leaky, or it may not just be opening very well because it's calcified and stenotic. And so it's treated the same way, the same indications for surgery and transcatheter options. And then there were 3 cards about what we can do better to get more awareness out there. And honestly, just you all being here and spreading the word. You know, if you look at Nadira's slide, 3% of people over the age of 65 have valve disease. So if you have 30 friends or 100 friends, you're going to know a few people that have valve disease. So just spreading the word out there, whether it's through social media or your get-togethers, let people know that if they have some signs that suggest that, well, maybe I'm just not as active as I used to be. Maybe I feel a little bit slower than usual. I have some funny swelling, or I can't eat the same way. Get an echo and see a doctor. And then also explore all your treatment options. As Sebastian mentioned, you know, surgery is the gold standard. And in addition to that, there are also many transcatheter options and research opportunities that can also help us push the boundaries of what we want to do. So with that, I think I got to most of the questions. If I didn't, my apologies. I may have just misread, or I can't read your handwriting, one of the two. But we'll be here for a few minutes after this event, and I really want to thank you all for the opportunity here. I want to thank the team, John, Cindy, Rebecca, Maya, and everyone for helping get this going from the foundation side. It's been a wonderful day. Enjoy the sun, and we'll be here for you. So thank you all.